So when I was a young physician, I really enjoyed my time in the coronary care unit. But I also noted that once people get sick with any type of cardiovascular disease, we never really cure it. We're just trying to palliate, to extend life, to improve quality of life, but we never actually restore health. And so noting that, I had the opportunity as a cardiology fellow in training to go to the Framingham Heart Study, which I think at this point everybody knows about Framingham. But it was really, for me, a transformative experience that taught me a lot about the life course of cardiovascular health and disease and the importance of prevention, certainly patient by patient as we address individual risk factors. But even more broadly in the population, there are many, many things we can do that can improve and extend lives. I think at all of the large national and international professional meetings in cardiology, we're seeing increasing emphasis on prevention, whether that's secondary prevention, patients who already have heart failure or atherosclerotic cardiovascular disease, or increasingly also primary prevention. But if you notice, I think most of the presentations that we see at these national meetings focus on medications, how we can use medications to reduce risk. And of course, for physicians, this is an incredibly important part of our armamentarium. But I'd like to see us do a little bit more upstream and think about what policies, what we can do as physicians, and what other interventions are needed to improve the health behaviors and, in fact, the social environment that really are the ultimate determinants of cardiovascular disease. So we really need to focus, I think, a lot more on those things, get clinicians involved in the game as both advocates in public health, but also advocates with their patients to try to improve the whole spectrum of cardiovascular risk. Yeah, I think if you look over the last several decades, at least in higher income countries, we've seen just remarkable improvements in cardiovascular disease death rates and smaller but important improvements in the incidence of cardiovascular disease as well. And I think it would be foolish to ascribe that to any one thing. Of course, it's been a series of medications and interventions and revascularization that we can do to prevent death at the extremes. But we've also gotten much better at identifying risk and applying primary prevention therapies. And I think if you look at the totality of evidence, all of these things have had a very important role in potentially reducing the burden of cardiovascular disease. But we have a lot to do, and I think the exciting areas of work now are not only in some of the new drugs and the new pathways we're identifying that could potentially reduce risk, but very much focused on the intergenerational transmission of risk. How are healthy moms able to transmit health to their babies? Or what sort of exposures that happen in the intrauterine environment set up our babies to have maybe not so much a healthy life course? So understanding those trajectories, the mechanisms such as epigenetics that sort of start that intergenerational transfer of risk, I think these are really exciting areas that need a lot more attention and in fact maybe targets for us to intervene on in the future. In the U.S., I think we've had remarkable success in particularly the last 20 years, in getting our foot on the throat of big tobacco and reducing smoking rates. And I think happily we've been able to be a leader in that regard. We are at a little bit of risk right now because, as often happens, industry pivots and they found a loophole with vaping. I think vaping, although it's marketed as a way to reduce smoking and help people quit, what we actually know is the way it is being picked up is by our youth. And fully 30% of our 7th graders and even more of our high schoolers have tried vaping within the last 30 days. And it's a highly addictive substance. So we are at risk of losing the battle, having almost won it with smoking in the United States. So that's kind of our urgent public health priority right now. But of course, our chronic public health priority that is setting the stage for a reversal of our gains against cardiovascular disease is our obesity epidemic. We are the fattest country in the world that there's ever been, and our diet is atrocious. We have a long way to go to make sure that we do a better job of providing a healthy food environment and ways to prepare it in healthy contexts for our population. And that ultimately is what's really going to determine our success or failure, is how we can combat the obesity epidemic in the United States and whether we can launch our children more successfully to healthier weights across the life course. I think one of the most alarming trends that I see as a clinician treating and caring for patients in the hospital is that we are seeing younger and younger patients present with acute coronary syndromes, with strokes, and with heart failure. And there is no question this is a direct consequence of having them live their life at much heavier weights, at much younger ages than we've ever seen before. You know, I can think right off the top of my head of a dozen or more patients who presented before age 30 with large heart attacks, with hemorrhagic strokes from uncontrolled hypertension, with consequences of diabetes that we didn't used to see until the 60s or 70s. And now those diseases are really ravaging young people, again, as a consequence of overweight and obesity that's been present for the duration of their lifespan. So I think we have a really important job to do to both raise awareness, but also work with our pediatric colleagues to make sure that that they are identifying and addressing this risk at much, much younger ages than we ever had to before. So I've had the privilege of being a volunteer for the American Heart Association for 23 years now, and it's a remarkable organization, as is ESC. I think the combination of altruism, focusing on improving health in the population, plus the very exciting science that is presented and fostered by these organizations, I think makes it an ideal opportunity for us to both enhance our personal careers, but more importantly, I think, network so that we can ramify and extend the application of our science to make sure that health is improving. I mentioned earlier, I have the privilege of being the program chair for this year's American Heart Association Scientific Sessions. So in that role, I liaise closely with the ESC planners. I was privileged to be a part of the planning committee for this year's ESC sessions. And as part of that, we proposed two joint sessions between the American Heart Association and the European Society, one of which will focus on prevention guidelines, moving from just thinking about risk to actually thinking about benefit. So which patients will benefit the most from our preventive interventions. And then the second session will focus on what I think is continuing to be a vexing clinical problem for all of us, which is heart failure with preserved ejection fraction, where we can treat symptoms, but we still haven't really understood the process well enough to intervene on the natural history of that. So I think both those sessions will be very informative and a lot of fun and helpful for clinicians. I think the theme of this year's ESC Congress of Global Cardiovascular Health could not be more timely. We know that 70 to 80% of all the acute cardiovascular events in the world are not happening in our high-income countries. They're happening in our low and middle-income countries, especially in the low-income countries. And if you look at, just to take one example, the burden of disease in India that is emerging, it's just astonishing. So I think we ignore that at our peril, regardless of where we sit for our day jobs. I think that the important work that the American Heart Association is doing, as well as ESC, the World Heart Federation, and many others, to reach out and partner with our colleagues in those low and middle income countries is really important. There are no mysteries about why there's such a great burden and an emerging burden of cardiovascular disease in those low countries. It's the same risk factors that have vexed us in high-income countries, but they're now becoming increasingly important, particularly as, unfortunately, diets worsen and people become more sedentary. And then there are, worsened challenges because of problems of access to health care, problems from access to, healthy food and water. I think all those things just magnify the problems that we've identified from these traditional risk factors. So again, this is a global problem that needs global solutions, and we all have to be a part of it. It's not that we can sit in our silos in high-income countries and just say, gee, that's too bad. I think we need to be partnering alongside everybody we can to help improve those conditions. But it really was a model for so many other health studies around the world, and the networks that have been developed across my field of cardiovascular epidemiology and prevention that have resulted from those various studies, I think have been a very important linker for us to understand how cardiovascular disease is very similar across the globe, but also how there are subtle differences and where points of emphasis may need to be applied. I've been really lucky to have both mentees and mentors who collaborate with people in China and India and Australia, in West Africa now increasingly, to understand how cardiovascular disease really affects different populations in different ways. So, thinking about our collaborations with the Public Health Foundation of India and the Center for Chronic Disease Control and Prevention in India, that led to some really important quality improvement projects that we were able to engage in with them, using AHA evidence-based guidelines as the basis for quality improvement in Indian hospitals. Salt reduction studies in communities in China we've been able to collaborate on, I think, are a very important way to understand the future of public policy. Clinical trials with the George Institute in Australia are increasingly, I think, going to be a focus of work for myself and my team. And then understanding the burden of cardiovascular disease and HIV, particularly in West Africa, which is such an important laboratory for studying that disease process. Now that HIV is a chronic disease that people survive, cardiovascular disease is really emerging as the dominant chronic problem that people have. So we really need to understand in that population how we can improve, reduce risk and improve quality of life as well. So, international collaborations, I think, are the bread and butter of not only research, but actually being able to apply what we know in important ways and improve lives. I think the biggest challenge by far is implementation. We know the vast majority of what we need to know to prevent the vast majority of cardiovascular disease, but we don't do a very good job at applying that in our clinical practice and across healthcare systems. We need to engage our patients better so that they understand and will adhere to recommendations. We need to, again, tilt the playing field so that healthy choices become default choices in their daily lives in terms of food choices, ability to participate in physical activity, reducing access to and addiction to nicotine products. All those things I think are going to be very important. But if there was one group I would focus on, it's our children. Launching them into more successful trajectories of cardiovascular health is really the only way that we're going to succeed and stamp out cardiovascular disease in the long term.